Center for Policy, Outcomes and Prevention at Stanford University. Jason will introduce the topic as well as the panelists for this session.
Good afternoon. Can you hear me okay?
Yes.
Okay, great. So this session is on population health advances, and this is the Health Technology Forum. So if you're in the wrong room, don't worry about it. You could fix it on the back, but we hope we'll have fun in this session. So first, I'd like to introduce some of our panelists today. The first panelist is Dennis Robbins. He is the person-centric healthcare expert, a guru, and he's been advising multiple companies across multiple sectors. Second panelist is Heather Wifley, and she is the Associate Director at USC Institute of Global Health. And our third speaker is Dr. Betsy Thompson. She is the Region 9 Health Administrator for the U.S. Department of Health and Human Services. So as you can see, we have experts from the private sector, from academia, and also from government. So I hope we'll have fun today. I'd like to begin by just asking our experts a general question, which is, what are some of the exciting health technologies that you've seen in the last 5 to 10 years, and what do you think this field is going? So we'll start perhaps with Betsy.
All right. Thank you all for being here and spending a lovely afternoon inside with us. My answer may be a little different than your question, because I just want to say that it's the most exciting thing to me about being here with you now is that I am with you here now, that you are talking at Stanford University about population health. This is not something that would have happened here even without the technology sort of background 20 years ago, possibly not even 10 years ago. I've been in the field of population medicine, population health, which I like to call it, it's often referred to as population medicine, for over 25 years. And it was really lonely for a very long time. And so this is testimony to how far things have come, and that there really are exciting advances. The fact that you have not just one, but a couple of sessions, as I saw on your agenda for this meeting, around population health. So that's one thing I just wanted to make sure that I had a chance to say. I think that there are many exciting factors and influences that are helping us move forward. Some of them are nascent, and I'm sure I will hear more about how the government in particular has been a little slow to drive the train forward. But again, at places like the Centers for Medicare and Medicaid Services, population health was not on the radar 10 years ago. And now there's all sorts of things from funding, from ways of doing funding, but also to the Innovation Center there at the Centers for Medicare and Medicaid Services that are helping, get us to the same place that I think many of you are here because you're interested in moving us. So I think there's just an awful lot of action out there. In terms of actual technologies, I want to hear more from all of you. I think there's a lot of exciting things. I think for me as a consumer, as a preventive medicine doc and somebody long involved in population health, just the wearables, the fact that people actually are tracking and care about what they do on a daily basis, what they eat. Again, I was like a vegetarian in 1973. Do you know how lonely that was? and it's no longer the case. So I just think there's an awful lot of confluence, and it's exciting to see you all here and see so many people, especially young people, that care about things in a way that I think no other generation really has. So I'll stop there.
What about you, Heather? I think we're just going to go this way.
Okay, so the focus of my work is largely on, let's say, the bottom billion of the world, the poorest populations on Earth. And I think one of the most exciting things that we've seen over the past decade is their access to mobile technology. And we now have over 7 billion cell phone subscribers on Earth. More people have access to cell phones than they have to clean water. And it's an incredibly powerful technology that we can use to access these populations. And so a lot of the work that I've been doing globally with the World Health Organization and with the International Telecommunications Union is taking advantage of this very simple technology. These are not smartphones, but stupid phones, basic phones. But the ability to get information and collect information from these populations that before we had no access to has been very exciting. And to see the leapfrogging that's taking place, and so that these populations have been able to access the internet much quicker than the infrastructure that is needed perhaps to bring clean water. They have access to the internet, and they've been able to gain information much quicker than we had it previously expected them to be able to do. So that's some of the technology that we're really excited and taking advantage of right now.
Thank you, Heather. I think Dennis's app told him to stand up. Your mobile app told you.
So I'm
time to stand up.
back to sitting and smoking. So to me, it's really important that we work in the health field and we know we can do something that's simple and undaunting and a small increment that can make a huge difference. I try to stand up. I stand up desk. I realize that if I sit down for 3 hours, that my caloric intake, my body metabolism was reduced by 30 to 50%. And there's a lot of little things we can do, simple, undaunting things, sleeping 8 hours, avoiding eating processed foods, that can make a big difference. I heard a young man speak about 2 or 3 years ago at the Clinton Health Matters Foundation. Bill Clinton was there, and I expected Bill was going to be the first speaker. Kobe Bryant was there, Herschel Walker, real cast of characters. This 13-year-old young man from Miami stood up and he said, you know, I'm 13 years old and I'm part of the first generation in the history of this country that will likely not live as long as their parents. Because of sedentary behavior, because of eating processed food, stress, homicide, a whole bunch of public health factors that we really can make a difference about. I thought, wow, that's pretty cool. So I wanted to talk with him. So I tracked him down in a morning exercise session where he was there and these other young athletes and the head of LA Fitness, and I was like 67 years old. I figured, what the hell am I doing here? And Denise Richards was running the workout, and Billy Blanc with Taibo did the next one. And I thought, wow, you know, this is cool. This guy taught me something because I was working with the Army and I was working with the Navy about looking at readiness and resilience and health and so on and so forth, and he taught me something else. He taught me about endurance. And I realized that when I learned prevention in public health, I thought prevention was really, really cool. It was the prevention of illness and disease. And I said earlier in the conference, I never get up in the morning and say, what a beautiful day, I want to avoid illness and disease. I talk about the things I like to do, how I like to do them, when I like to do them, to the extent I like to do them, in the manner in which I like to do them. It's about readiness, resilience, endurance, and the like. What's really cool from the technology sector is we now have little things like a Fitbit, for example. I don't wear a Fitbit, I use a competing product, but I used to wear one, and I lost 5 inches on my waist, and I went from walking 3,500 steps a day to about 20,000, or at least 17,000. And I started thinking more about healthy eating and sleep and all these other kinds of things. I learned that if I sleep 6 hours a day, it's like being 27% intoxicated. Little things incrementally can make huge differences. Where we'll be fun today about talking about the population, I think we need to rethink population health. I've never been excited about population health. David Nash and I used to work together and argue about this. I think it started off wrong. I think the potential is huge, but it's only huge if we see the interplay between the person and the population. If I find, for example, that taking 81 milligram aspirin can avert my likelihood of stroke death, cardiac death, by a certain percentage, I also want to know that in 100,000 lives, we can save 1 person cardiac and stroke death and kill 4 from a gastric bleed. As a person, I want to know that stuff. I want to know all that stuff. And I'm more than willing to share my data together. So I really think we need to rethink the interplay between the population and the person.
That's wonderful. So we heard a little bit about quantifying yourself, about the use of technology in global settings like improving water and sanitation. We heard about the history of population health. And when I asked the panelists, you know, what do they want to do with the panel, they told me they want to hear from you to see if you have any questions so that we could have actually a dialogue. at this point, is there anyone who has a question for the panelists so we could start this dialogue?
I have one. Would you tell us about what you do and what you do in the pediatric community with mobile devices, and then let's throw it open to them, because you do cool stuff. Please share that.
Oh, actually, I'm supposed to be a moderator, but
Go for it.
I'm happy to share that. So, part of my work here at Stanford is also, I co-chair the Mobile Health Initiative for Population Health Sciences. And my own work is that I try to foster health behavior change in children. I'm a pediatrician by training. And so when I look at the spectrum of things that we could change and to help kids build good habits, I started with a very simple model, which is to get kids to floss. And so, we all learn that we have to brush from our parents. And so it's sort of a habit developing process when you're a kid. But, flossing is something that potentially people have more trouble with because it's a little bit painful, sometimes it's pleasing. So we started 3-4 years ago building a mobile app called the Plaque Monster. And it's available at the Apple Store, so you could type in Plaque Monster and the app will show up. And we're just starting to test it. And so what we do is that we build storylines, 50 different storylines for the kids to play it for 6 months. And so every day they'll be logging in and to play with the pet, the tooth pet. And if the kids don't floss or brush, then they'll develop plaque monsters on their head. And then they have to fight the candy corporation in the environment. So we have this, they go to school, that the pets grow up from babies to, children to school children to adults and adolescents. And they go to school, they get exposed to the candy corporation, and they get special powers to fight the plaque monster if they floss for a long time. So we developed this gamification. And we're hoping that things like this will gradually, because kids play video games nowadays, most kids do, and we want to make sure that while they are exposed to video games for fun, they're also exposed to health-promoting video games. So we allow them to play about 2 to 3 minutes a day without game. That's the extent of the action until tomorrow. So we're trying to incorporate that into the daily lives of children as they grow up in this new digital age. So that's some of the things I do, and then we obviously do experiments to assess how to change people's behavior, because not everyone is motivated the same way. And so different social demographic groups, different age groups, different gender, there might be gender differences. And so we study that in the back end when we collect data. So that's what I do, but I'm sure you have more exciting questions for the panel.
Hi there, I just wanted to find out which types of activities or which, whatever technologies have the most traction, what are providing the best results, and are we tracking that? Is there a way to kind of see where the bar is and how it's being raised?
Well, I'm not sure any of us have the definitive answer to that. I would guess not, because it is changing so much, almost on a daily basis. I know at the federal level, I don't think we are tracking in a way right now that we know what's going to have the most impact. There's a lot of desire to do that. There are a number of efforts underway, but I don't know of any data source that can really do that for us now, except for maybe on a much more granular level in local areas and within certain subpopulations.
So my response would be that I suggest that you look at the Army's performance triad that you can go on online. They've done the best job I've ever seen anybody do in terms of giving people pointers and guidance using technology and information for the performance triad of sleep, activity, and nutrition. But they also get into mindfulness and balance and all very, very, very cool stuff. The Navy is working on something called the 21st Century Sailor. I'm working with developing some technology. The Telemedicine and Technology Research Command at Fort Detrick in the Army 2 years ago had a group of us get together to talk about, we had Lincoln Labs, IBM, Fitbit, Lark, who else was there, Basis, some of the tech companies. And there's been a study that the Army has been doing with Fitbit, and Navy doing some more. I was just at Fitbit visiting them last week to be able to do some stuff. Now, what's interesting in this domain is that many of these activity devices are seen by some people as being toys. My Fitbit caused me to lose 5 inches on my waist to make a big change. That's just me. I'm one person. I'm nuts enough where it motivates me. For other people, I think, as you said earlier, different strokes for different folks. Even different times of the day, things work that work for one person and don't work for another. My biggest frustration that I have with government is that CMS is still so heavily focused on disease and disease and disease, and not enough on health, that until we can move the needle of CMS and build a little bit of fire under them, and we keep paying for disease-specific categories. We know CPT was created by surgeons for procedures, and we're trying to move away from just procedures, but CMS can be a huge help to get us moving forward. And there is some discussion. Even the Innovation Center has been tied so much to disease. Patient-Centered Outcomes Research Institute has people that represent diseases. We need to really change the needle from a healthcare system to a system for health, and not ignore those people that have unhealthy, not lifestyles, that as well, but diseases that make them in a situation where they need certain kinds of services and to manage their illness or disease. But isn't it better if we help them get rid of it? I mean, losing that 15 pounds can prevent that pre-diabetic from becoming a diabetic. And I'm sure you can respond to these, both of you as well. Let me shut up for a minute. Go ahead.
Well, I would just speak a little bit about what's happened at the global level in terms of evaluation and monitoring of some of these programs. What we saw at the global level was kind of death by pilot, and I think we see that somewhat here nationally as well, as there's so many initiatives taking place and small data sets, showing small effectiveness or not. But what the World Health Organization finally said, we really need to have some testing at a very large scale, national rollouts to see what the large population effects of these programs would be. So they launched about 3 years ago the Be Healthy, Be Mobile initiative. It's a collaboration with the International Telecommunications Union. It's a collaboration between multiple sectors. So academia, myself, were involved, especially on the monitoring and evaluation side of it. But also governments are the main partner, implementing partners, and we have industry also deeply involved as a partner. Interestingly, because the World Health Organization traditionally does not partner with the private sector, that was one of the reasons why the International Telecommunications Union was brought in. They're the only UN agency that actually has members that are members of the private sector as part of their organization. So where WHO hasn't been able to partner with the private sector, they are able to partner with ITU and then bring in that partnership. So that's been innovative and a great collaboration for them. But in this program, what they've done is they've run full large-scale rollouts now in 9 countries. The countries have 6 toolkits that they can choose from. These are text-based, largely simple phone interventions, but they deal with diabetes, tobacco, physical activity, cervical cancer, tuberculosis. There's a number of them that they can choose from. I know, for example, Costa Rica chose tobacco cessation, and they've been implementing it now for 3 years, and there is national evaluation data showing the effectiveness of that program now. And there's countries that have been picking it up and implementing it now. And one of the real goals of that is exactly to show what you were asking, which is what is actually working at a very large population scale at a national level. How do we integrate these programs directly into a health services system and not just as side projects or outside of the traditional system?
And I think getting back to some of the same things Heather was saying, but here on a domestic side, even though my initial response was that it's early, things are changing a lot, we really do need it's, I don't want to say we need more research. We always need more research. I mean, there's always more to it, but there really are questions that remain unanswered. However, we are learning enough about sort of the conceptual framework of what sorts of things work to really help guide us moving forward. And the same thing that's worked globally, I mean, Text for Babies that's being used domestically, it's been done and has demonstrated benefit too. So I think we do know a lot about what can work, but when you say what's best, I mean, one of you is going to develop what's best, right? I mean, it's still a process. So getting back to CMS though, full disclosure, I was the Regional Chief Medical Officer for the Centers for Medicare and Medicaid Services before coming to the Office of the Assistant Secretary for Health, where I am now. And I did a lot of work with the Center for Medicare and Medicaid Innovation when they were first getting started and some of their initial rollouts. Things to understand about CMS is that the Innovation Center is a little different, but most of CMS is very tied to the authority that they are given by Congress for both what types of services they can, whether there's a category of service they can pay for, and then how that's actually paid. So, for example, I'm somebody, my whole life has been about prevention. And when I went there, I was, and the ACA had just been passed, and one of the things near and dear to my heart in that was about coverage of preventive services for Medicare as well as for other populations. And I realized that there were at least 2 services right then that met the criteria for full coverage with no deductible under Medicare that weren't being covered under Medicare. They were covered, but not as preventive services, so they were copays, and so I immediately went to work to try and help straighten that out. But my point being that they have to fit in a certain category to even be considered an eligible service. And so much of there are clinical preventive services, those now we're pretty good with, but there are other things that are about community health that we know work really well when you're talking about a whole population, not necessarily just every single individual within the population, but things that we could do at the community level that CMS just does not have the authority to cover. Now, under the Innovation Center, what I think is cool there, in particular, is that given a few restraints, they can test, do pilot demonstration projects, basically. That's been doable in the past at Medicare and Medicaid. What hasn't been doable is so you do something on a population scale, you try a text program, it works great, but that's it. I mean, without going back to Congress and getting authority to roll it out nationwide, okay, you had a successful demonstration for that particular population. The Innovation Center, actually, if they can show that a demonstration either maintains or improves quality at either the same or lesser cost, they don't have to go back for congressional authority. They can roll the program out nationwide. That is huge. I think it's untapped. I shouldn't say untapped. There have been some things that have happened, but it's a relatively untapped resource that goes away in a few more years if we don't do something with it. So that, again, is part of why I think it's exciting now. This is just, we've never had that possibility before. So I wanted to make people aware of that, especially those of you who are, the developers and innovators. There is a reason to have a conversation with the Innovation Center and CMS.
That's one of the coolest things about the Accountable Care Act is that if something works at the same or less price, the Secretary has the authority to implement it. That's so cool. That's so cool. If anybody wants to badmouth the Accountable Care Act, don't forget about that, because it's really cool.
Any other question from the audience?
With all the population health, with all the data that we have today, what do you guys think are the most prevalent diseases in the nation that that we can reduce by clinical intelligence tools? Asthma or cancer or
Well, I like to think more than about diseases, because really what we need to deal with is already been said. It's healthy eating, active living, tobacco cessation, and I would add emotional well-being to that as well. Because when you talk about the most, well, you have to think about, okay, what diseases are preventable, and there we're talking about cardiovascular disease, diabetes, certainly a significant amount of cancer, but cardiovascular disease, diabetes, lung disease, some of the cancers, all of those, the healthy eating, active living, tobacco, tobacco-free living, and emotional well-being.
A lot of our lifestyle diseases.
Yeah, at the global level too, the WHO's focus is on the 4 chronic diseases that cover 80% of the non-communicable disease risk, and as I said, chronic obstructive pulmonary diseases, cancer, diabetes, and cardiovascular disease.
Yeah, so, I mean, this we've known, but I think we're starting to move the needle in places, but unfortunately for some of the global areas, they now have this like trifecta of they're developed enough that they have all of the chronic, non-communicable diseases. They're underdeveloped enough that they're still dying, in great numbers from things like tuberculosis even. And then we have climate change, which has disastrous health effects that we haven't realized yet, but they are there and they are coming. And some places are already seeing it. So I think that we focus much better, even when we want to prevent disease, we'd be much better off focusing, as Dennis would have us focus, I think, on health rather than on disease.
Yeah, and on the person rather than the population becomes another component. I want to add something as well on this particular panel. We, I think, have talked more on this panel than anything at this conference about issues across the age spectrum. It hasn't been about the baby boomers. It hasn't been about it's the issue of the health of our nation. It's the health of the world that we need to be concerned with.
I want to come back to the issue, again, of the health and the systems. So one of the great things about what's happened with the Global Mobile Initiative is that in Senegal, for example, a very large diabetes program was developed and launched nationwide, and then the Ebola outbreak occurred. And the entire system was transferred immediately from diabetes to Ebola information sharing. And that was very nimble and happened very quickly and was very, very effective. And so again, when we think about this, it doesn't necessarily have to be disease specific. It's really system specific and how we can get information to populations very quickly.
Moving to the implementation stage, how do you see forward movement within CMS as well as Medicaid on community, home-based community care? That's not an area I feel particularly expert in. I left CMS a couple of years ago. It is an area that I know is extremely important. And there's more information all the time emerging that you probably saw that the Chief Medical Officer for CMS and the head of the Innovation Center, Dr. Patrick Conway, spoke, I think it was yesterday, about how there's a new pilot program where independence at home, that's not exactly a new pilot program, but where they're actually going to pay for Medicare beneficiaries to receive care at home, people that would actually probably qualify for being in a long-term care facility, but they want to stay at home. They're actually going to start paying for home visits. And they know, I mean, there are data out there showing that I think you can reduce costs by something like 17% and keep people at home healthier where they want to be. So I think it's an incredibly important area, but I really don't feel, I have not thought deeply about that to tell you kind of the way forward. I think we're going to see more and more about that. I think there's a related, but it's not quite to your issue, that is about housing. It's about being at home at all ages and being healthy. So we know there are a lot of kids that you might see in your practice whose asthma is exacerbated because of the housing conditions they live in. So much of health, we talk about lifestyle factors, about exercise, eating, but there are many other things that are very, very little of what actually helps to keep someone healthy can be controlled or done in a healthcare setting. It's about where you live, in work and play. And so I think that there is a lot more to be uncovered, sort of the layers of the onion when we talk about home, and not just home-based care, but having healthy homes in the first place.
I could add a bit. A friend of mine some years ago did a study for Social Security on home care. It's the American Society of Home Care Physicians. It's got 1-800-CALL-DOC in San Diego. The population had a mean age of 84, 5 clinical comorbidities, 5 dysfunctionalities of daily living. Everybody had CHF at least. And the readmission rate of 137 patients over a 12-month period, and actually it's not a rate, the number was 1. And 1 was somebody that was being managed by someone new to the program. Okay? Otherwise it could have been 0. And by doing things in the home, like providing physical therapy, they do urea breath testing for Helicobacter pylori, for x-rays, and for some other very, very minimal kinds of things. You can keep people healthier. But by the way, a major cause of death in his population were gastric bleeds from insects. It's kind of interesting.
You know, part of keeping people healthy at home, again, does get back to the technologies, because, 10, 20 years ago, we couldn't know what a person's blood sugar was instantaneously without sticking them with a needle and being, and having something more invasive done to them. And now there are many things, and many more to come, I know, in the pipeline that can help us keep people at home healthier and longer. So it's great.
I would like to know more about design thinking in public health and global health. Just like the video game for health kids to floss, I think it could be an example of design thinking.
I can comment quickly. We're doing a lot of design thinking at the University of Southern California, and we've done a lot of the gamification and a lot of different programs. And I think the most important thing when working with the populations that I work with is that the ideas and the initiative comes from the population themselves. And so we can kind of design it and implement it, or they design it and lift it up. And really what we found is that the more participatory, community participatory nature that we have, the more effective and more applicable the programs are. So I work a lot in rural Uganda, working with mothers to develop applications using their cell phones, which they do have, and they do have access to texts every day. What do they want? We think of all of these health information. They want a taxi service so that they can get to the clinic when they want it. And they want the taxi to be pink, so that their husbands know that it's very specific. And they want to run the application themselves so that they can make money. These are things that we would have never really thought about, like that's the mobile app that they want, but that's what they came up with. A lot of it has to do, a lot of the design that we're dealing with is giving voice to populations and how that can take place. And so it's one of my favorite things. I love going to the game group because they take off their shoes at the beginning of every meeting. And in our healthcare meetings, we don't usually take off our shoes. We don't usually get very creative, but it's one of the most exciting things about working in this space for me from that.
Can I ask a question of the panel or the audience as well, the participants here? So to me, we've been talking a lot about promoting healthy behaviors, promoting healthy lifestyles, lifestyle change, and it's not that hard to get somebody to lose 5 pounds or keep it off for a couple months and so on and so forth. To me, one of the real issues where technology can have a huge play is how we sustain lifestyle change, whether we do with AI and natural language processing or whatever. What are people doing, or how do we deal with that idea of sustaining a healthy lifestyle change? To me, that's a critical issue.
I'll just point to this, because I use it every day, and, oh, right here. Oh, I'm sorry, my iWatch. Sorry, I thought everyone here would know that, I'm sorry. Maybe not. But yeah, what it does is it tracks our, how many steps we walk, whether it's been telling me all day today to stand, which I haven't done. But it is actually sustainable because I like to see my circles, and this is something if you don't have one, you won't realize it, but it actually tells you if you've completed the goals for the day, the calories burned, the steps walked, and what have you, but that's sustainable. I actually had a question for Heather. Can I ask?
You got the mic.
I got the mic. You just talked about gamification in resource-strained communities such as Uganda, and I was thinking of Africa and India. And you worked with the local people there to actually create something that works with them, because there's the whole societal construct of the home. If you want to create change, you actually have to take the cultural and societal construct of the home to actually implement it. You could do something for the women, but if the husbands don't support it, if the families don't support it, their cultural norms they're going against. And I just wanted to ask you if you were able to overcome some of that, because those are generational things, so I was just curious.
Well, I think that that's one of our big challenges, even the use of technology, to access to the phones, who in the home has access and owns the phone versus who can utilize it. Those are all challenges that we're dealing with. The real issue is what's coming in the future, and the development of all of these low-cost games, gaming consoles, and how we can utilize that power to bring some serious topics and some behavior interventions into those games, and so they're not just blowing something up, but that they're learning from these programs that we're developing. And so there's a lot of serious gaming programs going on around that. I think that the issue with there's not necessarily a culture of gaming in some of these, in many of the places where I work, especially not among adults. So they're, how you phrase it is also in, interactivity and engagement versus just simply play. Although I think the power of play is so important, and even if it's not digital, in my work I increasingly integrate play into all of our interventions, and that I've learned from the digital gaming work that we've done.
I'm going to push your question. I don't want to let you off the hook, okay? So I wear a Garmin. Sometimes I wear a Fitbit. Sometimes I wear all kinds of different trackers. I'm fortunate enough that companies have me look at them because they know I speak in this area. And other people end up buying stuff because they don't want to use trackers. So for me and for you, it made a difference. A lot of people just buy the thing. If you go on eBay, you'll see used things all the time. A lot of people want to figure out, calibrate what they're doing, and they throw them away, and it's meaningful to them. So for you and I, it's good. And for maybe another 60% of the population, it may not be. So the thing is different strokes for different folks. Each of us is motivated in different ways. A lot of people are motivated by peers being there that can provide a social framework. In fact, there's a company called Spire that's doing that. Other people are motivated through again, artificial intelligence and natural language processing that learns, that is personalized for them. But I think that this isn't enough. And this is enough, and particularly healthy eating, avoiding processed foods. I have sleep apps on every one of my activity monitors. They've never changed my behavior one iota. Now my steps it has, and my flights it has, and other things it has. But some people don't want to wear everything, and they don't. And other people love it. So let me see if we can get somebody else to respond.
Well, and I don't need a microphone, but I
We
just
want to tape it, so take the microphone.
Oh, okay. So that really doesn't do too much for people who are in underserved areas or populations that cannot afford to buy some of the things that we have, the gadgets. And those tend to be people who need the help the most in some cases.
Absolutely.
So.
Yeah, I think that's so important, and I think, it's great that those of us who are motivated, I have my Fitbit on too, but it's almost preaching to the choir. I mean, it's often the people that either they're just early adopters or they're already motivated. So how do you get folks either the motivation, and I would argue that a lot of those folks in underserved areas actually have the motivation. It really is trying to see the way out and see the way forward. And that's where I think I may have quickly glossed over when I talked about healthy eating, active living, tobacco-free living, emotional well-being. And it is hard to kind of operate on all four of those, what I think are really four very important legs to a stool of health when you're living in poverty and have other issues. So that's where I think, I obviously have a bias. I've been in government for 15 years. I haven't spent my whole life in the public sector though. But where policies and other things that really are at the population level, and some of you may have noticed when he said it's really about, you know, the person and not population. I think it's absolutely about the person, but there are things we can do at the population level. Policy, legislation, things like that are one of them that are just so incredibly strong. So some of you may know that the Surgeon General put out a call to action for walking and walkable communities last fall. And, you know, a Surgeon General's call to action in and of itself doesn't necessarily make it so, although it helped us a lot with tobacco. And we're hoping we can really make it work more around just educating folks around what they can do to make their communities more walkable, to do sort of a health in all policies stance, and many jurisdictions are doing that. So again, maybe doesn't speak to this audience as well because it's not exactly technology, but it opens up the possibilities for technology to expand in areas that are really embracing health in all policies at a city, county, state level.
Yeah, I think I would totally agree with that, which is it has to be integrated into our systems and into the environment in general that supports the use or supports the integration of that data into care and a patient's choice. They're, you know, otherwise they're fun trinkets and they're entertaining for a little while, but are they really bringing that population change? I always like to joke about my dad, who's not one of us. I gave him the Nike Fit band or whatever, fuel band a year and a half or 2 years ago for Christmas. He loved it, he put it on, he started exercising. I came home to visit, I asked if he could go for a walk with me because I was so excited to hear he was walking. He said no, his fuel band's out of battery. So there was no motivation left to go walk with me if he wasn't going to get his points. But his fuel band then stopped working or just kind of got old and now it's in a drawer. And you know, I think that there's a lot of Fitbits and bands in the drawers throughout this country that are not being used. And I think it comes back to the environmental issues and the cues. If you're not in a healthy environment, if you're not being forced to walk, to interact in your daily life, you're not going to be supported over the long term. So we need large-scale policy change, and we can integrate that technology into those systems to provide the data to support those interventions. But the data itself is not the answer.
You raise such interesting issues. So one of the issues that I have with the Apple Watch is I don't want to have to plug it in every day. I'm not going to talk about the company, but another company makes a product that gives you most of what you need. The battery's good for a year. It's got a great form factor, it's waterproof, it's simple, and you don't need to have your phone with you. So for some people, that's great. For other people, they love the Apple Watch because of some other features. The one that I have has all kinds of cool stuff on there, most of which I never use, but I like it anyway. But different strokes for different folks again. But the thing that's problematic with some of these things is if you lose you don't have your charger with you, your battery stops, you lose that momentum. So I was at Medtronic recently. I was talking with them about why don't you just start embedding these under people's skin, and they'll have them all the time with a battery that lasts like. Well, it's going to happen. They're doing clothing in China. Wearables, it doesn't mean just on your wrist. So there's some patches, all kinds of things, life shirts, name it. There's all kinds of stuff.
They have sheets now.
Sheets, yeah. They have ones that spray water to wake you up in the morning, or a little bit of warm water to help you go to sleep. There's all kinds of stuff that's out there in terms of technologies that make it simple.
My name is Ivana, I'm with Sutter Health. I want to pose a little bit different question. I think we know that there's a small proportion, as we think about population health, there's a small proportion of patients who are consuming the largest amount of healthcare dollars. And a lot of these are the high utilizers. And then my question is, and I think a lot of the challenges we see is that this group of patients do not want to participate. They decline, they refuse services, and it's not for lack of trying. I think there's certainly a lot of resources devoted to it. We're all trying to help, but again, for whatever reason. So my question is, is it fair then to hold healthcare systems accountable for quality or metrics of this group of patients who choose to decline? And what does it mean in the larger context?
Yes.
Oh, right.
I hear you. I was the chief medical director of a health plan. We had patients with diabetes who, no matter what I could think of, weren't going to change. On the other hand, those very same folks that you say, they don't want to do it. It's like, yeah, they don't want to do that. They don't want to wear the Garmin. They might not want to, but most people actually want to be healthy. It's just like most smokers actually want to quit smoking. Do we know the best way to help each individual? No. Can we be expected to know the best way to help every single individual? I'm not sure. Dennis might say yes, because he's all about the person-centered.
No, I agree with you.
But we can do more, and health systems can do a lot more than they're doing. I think we have a very long way to go before we are really a person-centered care in any way, shape, or form. Even the organizations that get touted as being there, I've experienced them as a patient recently. It was not person-centered care. So I think we have a long ways to go. And when I talk, I used to have to talk to groups of physicians all the time who would not be necessarily happy, but that they were being held accountable for things that, yes, they were about the behavior of their patients. And physicians aren't trained to deal well with behavior, but you know what we need to be? We need to be all good at motivational interviewing. We need to understand how to do that work. So can you succeed with every single patient that has whatever chronic illness, at making them better? No, but we know that we can do a lot better than we currently are, even with the tools we currently have, and you all are going to help us get even better tools. So
We have an initiative in San Diego called the Be There campaign. It's funded by CDC, Million Hearts, CMMI grant, a whole bunch of things. And the goal is to reduce cardiac and stroke death, primarily for people that have the cardiac and diabetes-related diseases. So how do you engage people? How do you engage an entire community? We've got the medical directors all together, the Navy, the VA, the Department of Public Health, they're all working together. And how do you engage the person? So they developed what's called the Be There campaign. So Be There was put together by Ralph Panirska, who was a place kicker for the Chargers, and Greg Anton, who was Lance Armstrong's Tour of America campaign director. Be There shows a picture of Grandpa and grandson playing chess. And slowly Grandpa fades out of the picture and there's no more Grandpa. And Mom and Dad and the 3 kids. And slowly Mom fades out of the picture and Dad is left with the 3 kids. Be there for the ones you love. It is amazing because it gets to the amygdala. Okay, it's not giving you information. It's that fear thing. I need to be there for the ones that I love, for the ones that I care about. It is just super cool. Anyway, just an aside.
Yeah, I wanted to know, how are you making your mHealth programs evidence-based? Are you using, like for plaque monsters, is there a certain theory, behavior change theory, that you're using for young children? And then how do you measure that behavior change in young children with a mobile health application?
Yeah, it's a great question. So when we started with the app design, we actually reviewed 20,000 articles on behavioral theories. And we came up with a list of about 25 different theories, and then we break down each theory into behavioral constructs, theoretical constructs. And what we did was we embed each of the behavioral constructs into the game design. So with each construct, we could turn features on and off. So we could simultaneously run hundreds of experiments. So that is actually the platform behind this. So with this, then we could begin to understand different subgroups of population, what motivates them. So I'm pretty sure what motivates me as a 45-year-old Asian male is going to be very different than a 16-year-old African-American female, right? So all of us are motivated differently. So with the big data analytics now, it's being popularized, and we could actually do some predictive algorithms, and then we could actually target interventions directly at specific patient populations that fits a certain persona. So when we do the app design, we actually think about the different types of users, and we design the user experience based on different persona. And in some cases, you could actually pick your character. And so it's through sort of customization and popularization. So popularization part is actually, the app itself is being popularized by a common platform like the App Store that you could just download. but the customization part has to do with how individual users engage with the game. And so the science of behavior change is actually in the databases when we start to collect people's behavior through the app and then analyze large amounts of data and try to figure out which subpopulations are motivated by, which part of the behavior theory, the behavior constructs. And so, one of the things that we've been looking into is how to sustain behavior, right? So, I don't know how many people read the book Nudge, How to Nudge People, right? Thaler and Sunstein. And
Behavioral economics.
so behavior economics. So nudging is sort of like how do you change people's behavior without changing the economic incentives? So people have known for a long time that 5 minutes. So I'll try to be brief, but I think you enjoy this.
They've known longer than 5 minutes.
Yeah. So people have known for a long time that if you put healthy foods at the kids' eye level in the cafeteria, they will buy more healthy food. You don't have to change the price of the food. Just the fact that it's in their eye level, they will pick more healthy foods. But if you put French fries at the kids' eye level, they will just buy more French fries. That's a nudge. That's a type of a nudge. But that's not enough to sustain behavior change. So how many of you have United Air miles? Right, all of you. And how many of you tried to take a United flight? Okay. So even though the service is not so great, you still go for it, right? So they got you hooked. Okay, so basically our experimental design will involve hooks and nudges, and different combinations of hooks and nudges in our experimental platform. So it's currently under study. I'm going to actually be presented in a big data conference in a couple of days. So if you're interested, you could watch.
So that nudge is actually embedded participation. It gets you hooked,
Exactly,
hook, and then you go from there.
I might just add, that's one of the roles for academia, yay, and our partnerships with different groups is to try to bring in some of these theoretical constructs and make sure that they're evidence-based and the outcomes can be used at a research level. And I think that's some of the, especially the early on inventions and use of this data wasn't necessarily done at a research level. It was done for a consumer at a fun level. And one of the things that we've been really trying to push is how can we get it to a level which could be really utilized at a research level, and also for physicians, and could be really evidence-based data and not just consumer fun data.
Thank you for a great panel. Larry Ozrin with Clinical Informatics and Informed Health Technologies. My background is programmer, trauma surgeon, and I'm deeply involved in health policy at the state and national level. And so I wanted to come back to Dennis's question, although I think that you, as a panel, answered it in lots of different steps. I'm fond of saying that it's process, not product. And so while the product will occasionally fit the process of an individual, it doesn't fit the process of every individual. And I think that all of you said that in several different ways, but sort of as an abstractive concept, we need to focus on the process. And I think as you were just talking about in terms of nudges, the goal has to be small incremental steps, and those small incremental steps are going to be different for every person. So part of the research piece is, what are those different incremental steps? What are the different types of people that they would actually help? And then to the point of continuance, there has to be a reward somewhere in there. Again, to the point of, whether it's miles or whatever it is, those rewards are going to be different. The rewards for one person aren't going to be rewards for someone else. It's like if you're in the jungle and somebody says, hey, we're looking for diamonds, and if that's the thing that's most important to the people in the jungle, that must be where the diamonds are. No, that's where the food is. So the rewards have to match where the person is and what the person thinks is a reward. So it's nudges and the rewards, and they have to be identified for the proper person if we're going to get to the behavioral change that is made over time and then stays.
And I think
Keep the mic.
beyond just nudges and rewards, I think it's also about sort of the mode or the motivation. This is obviously a techie group, so you like technologies. But I'm thinking about diabetes prevention. We know that we can prevent, we used to say 50%. I'm pretty sure based on the epidemic that it's probably 75 to 80% at least of diabetics now. We could prevent the diabetes from developing in. It's starting because of very good academic research with the diabetes prevention program research. But I was then involved in it in a couple different ways. One where we were actually doing grade school, second, third grader curriculum about nutrition that was standards-based, so they were learning science and math, but it actually was diffusing into the home so that they were eating better. We also did coaching in the homes. This is in a Hispanic community, so it was also mainly around nutrition and physical activity. Well, Sean Duffy, who was in the M-Health program, I think, and developed a mobile diabetes prevention platform, is now marketing it as a proprietary product through employers, health plans, and others. So that's another completely different modality, all delivering the same information, giving people nudges in different ways. And I think that speaks to your point.
But at the same time, we know that information alone is not enough, right? The thing that was most effective at reducing smoking in the state of California was raising taxes, not giving information.
So since you still have the mic, so let me see if I got what you said and see what I'm missing, okay? Small changes incrementally can make huge differences. That part I got. You didn't say 24/7 continuous. Did you mean to?
No.
Okay. And that we need to make it where it's not daunting or impossible or unachievable. And we have to provide a mechanism ongoing to be able to support people in whatever ways we need to make that difference sustainable. I think that becomes absolutely critical.
I wouldn't say in whatever ways we need to. I would say in rational ways that meet the needs of the person.
Got it. I think you're correct. Your formulation is better than mine.
So I wanted to thank the panel and thank the audience for participating in this panel. But about the only job I have is to make sure this stops on time. So if you want to have further discussions offline, you're welcome to. Thank you very much.